Well, let's get started. Welcome to the last edition of our Becoming a Senior series. We can add parts to this if you all have any other questions about being a senior, but so far we've done admissions on the wards. We did cross cover on Friday, and then today we're going to be talking about ICU admissions. And so, ICU is a tricky place, especially at Denver Health at night, where you're sort of riding solo and are making a lot of the decisions on your own rather than having an attending in-house like you do at the medical ICU over at university. And so some of these even trivial decisions become a lot more amplified when you're by yourself. So today we will talk about how to consider the next few hours and then the next day simultaneously, which is what you have to do when you're admitting an ICU patient. We're going to delegate some tasks, and then we're going to grow our confidence in relying on our interdisciplinary team in the ICU who are all very experienced, and when they alert you to something, take that seriously. So as opposed to the ward admissions module we did, ICU is a different hurdle, right? So patients need frequent reassessments after admission, which we don't really think about on floor admissions. Usually I admit and forget because I have a lot of other admissions coming in. But in the ICU, you need to set aside time to go back and see the patients you admitted earlier that night because they're often changing, things are evolving, and so you need to keep an eye on that. And at the same time, you're juggling more admissions, you're juggling time-consuming procedures, you're often the code teams, you're going to other codes around the hospital, which then become an admission for you. And then you're also being asked to go see floor patients, and often those become admissions for you as well. So a lot of information coming in at the same time and trying to just prioritize them. And today, hopefully, we'll find some answers that you can give right away to lessen that sort of mental burden. Okay, so I like giving hot tips for all of my conferences. So for the ICU admits, the hot tips are that as opposed to the 30-minute rule that I have on the wards, in the ICU, my rule is really to see the patients as soon as possible when they're called to me. And so when I'm talking with the ED on the phone, I'll ask them, hey, do you think that the patient's going to be down there for a few more minutes and I have time to come down to see them? Or are they rolling up here and I can see them up here? But figure out where you're going to see the patient and see them right away. Someone must always and immediately answer the admit pager. These patients, of course, are much sicker than our ward patients, and sometimes you need to be at the bedside making active decisions, pressors, intubation, things like that. And so someone must always answer the pager. And so a lot of times, when I was a second-year senior, I had my ICU month at the university pretty early on, and I wasn't very used to doing 28-hour calls. And at night, I just sort of was a delirious, pretty sleepy, but still getting these really challenging admissions. And I felt afraid to ask for help from the attending. But I think looking back now, I really wish I would have said to my attending, hey, I'm feeling really tired, and I think that I'm not making smart decisions right now. Is it okay if I go lay down for like half an hour and you can hold a pager? And then I'll come right back and get back to work. And so please, my advice to you is don't be afraid to ask for help. And if you feel like you're really tired and need to lay down, hand that pager off, lay down for an hour, and then come back refreshed so that you can keep working and providing the best care that you can. And I think Amelia will agree with me on that. And then the last
100%.
point, yeah. The last point I have to make is in the ICU, POCUS is your best friend. Even if you know a pathology, throw an ultrasound probe on and see how it looks like. So if a patient has no pneumothorax, see if you can find that transition zone. If a patient has a pleural effusion or a chest tube, see how that looks on an ultrasound so that for future patients, you have a point of reference. A lot of times when I admit patients with kidney injuries now, I do my own bedside ultrasound to see if I can see hydronephrosis, which is very easy to pick up on. And then when I'm talking with renal, I say, hey, they don't have hydronephrosis. Happy to get an official ultrasound if you still want, but this is what I saw. And this is really helpful on the weekends when the ultrasound techs aren't always in-house. And so you can delay a procedure or delay having somebody come in the middle of the night when you can do this at the bedside. Okay, so for Megan and Jordan today, they are going to be our two upcoming seniors who are going to admit patients to the ICU. So you have gotten a promotion. You're at the Denver Health MICU now. This is sort of an overnight scenario. And the attending and fellows are available, but they're on home call. And so let's get started. So your pager goes off, and it's the ED admitting to you to the ICU. And so let's get started. So what I'll have you guys do is, of course, you're going to call the ED back right away. Like I already mentioned, for ICU admissions, you're going to call back right away. So let's get started. So here's what the ED tells you. The ED sign out is that this is a 56-year-old man with type 2 diabetes, hypertension, stage 3 CKD. His family brought him in because he just looks way worse than normal. His legs have been getting swollen. His pants don't fit, and he's just been too fatigued to go to work for the last week. Today, his family got really worried because he didn't eat any of his meals and fell asleep at the dinner table, which he never does, and he loves to eat. And so they were like, this is really concerning. So they brought him into the Denver Health ED. And the ED's like, look, when he came in, he was hypotensive, a little bit tachycardic. We got a sepsis workup started for you. Because of all this edema, we didn't really feel super comfortable giving fluids. So we've honestly haven't messed with that right now. But because he was hypotensive, started him on an epi drip for you. By the way, he also is in renal failure. And don't bother coming down here because I just saw him being rolled up to the ICU. So he should be up there in 5 minutes. Okay, so this is the scenario. Tell me what you guys are thinking and what you want to do next. How are you going to approach this admission?
I mean, first of all, I guess he sounds sick if he's tachycardic, sounds like he's a little altered and volume overloaded. I think he had the background history of diabetes, hypertension, and CKD3. So with his, now in renal failure. So from a volume overload perspective, there's always heart, kidneys, and liver. Obviously, I think you would prioritize the kidneys and then maybe the heart after that, with having diabetes and hypertension and renal history as well. So I'm thinking about all three of those things. I think I would be thinking about, he's on pressors. If he's not urinating and able to get volume off, is this going to be a scenario where I would eventually have to get dialysis in order to volume management as part of the AEIOUs? I'm wondering, is he oxygenating well if this is a heart problem and if he has fluid overload? And again, he's going to be more susceptible to infection as well, given his history of CKD. So this certainly could be sepsis that's pushing him over. And do I need to start broad spectrum antibiotics shortly?
Okay.
And then what are his electrolytes? I'm going to probably want to be checking those in case he has some arrhythmias, particularly like hyperkalemia or something like that.
Fantastic. Megan?
Yeah, I mean, I think you pretty much covered it. I feel like it seems like his renal failure is maybe secondary to whatever is potentially an infection that's causing him to get so sick. Because I feel like just in my week here, he lost CKD5 and they're not in acute renal failure. So something was kind of the impetus there. And I don't know, I think it'd be a little tough, but I wonder if maybe he could still use a little bit of fluids, like if he's intravascularly down. But I agree with Jordan that I would be nervous that eventually I would need some help getting that off with his kidney function later. But I think Jordan did a really thorough job covering most of the things.
Yes, awesome. Okay, so you guys are doing a lot of thinking up front. Let me ask Amelia. Amelia, when you approach ICU admissions, tell me sort of how you approach them.
Yeah, I think it's important to have kind of a systematic approach. And I completely agree with everything you guys are thinking. And I think that's kind of things that start running through my head as I hear the story. But when I open the chart, the very first thing I want to look at is the vital signs. Because I think those are going to tell me, you talked about sepsis, you talked about heart failure, you talked about kidney failure. And just by looking at the vital signs, I can start to get an idea of maybe what's going on there. Like, he's not febrile. I feel maybe less concerned about a sepsis, but certainly keep that going. his heart rate's pretty quick and his blood pressure is really low, which I think immediately makes me think of like a volume, as we said, like thinking the volume overload side, worried about maybe a pulmonary edema from either acute renal failure or progressive heart failure. And I think, and then looking at this exam that I assume, like, because I see him right away as soon as he gets to the unit, with the edema, elevated JVD, kind of some diminished aeration, and anasarca overall, and then the cooled extremities, again, really pointing me towards probably the cardiac system more than other systems. Yeah, I think that's kind of where I'd start.
Great. So Amelia made a point that I'm trying to make with you all here, which is that you are really going to have to differentiate between how you approach floor admissions versus ICU admissions. And I think both of you did what we are sort of taught to do as interns and what the chiefs have been teaching you to do all year, which is to start thinking about this differential right off the bat, moving things up and down. And that works well for floor admissions and not so much ICU admissions. And it's going to happen in the background because our minds can't help but start coming up with differentials. But like Amelia said, really the thing you're going to jump to in the ICU is looking at the vitals and looking at the patient. And like, even if you're not coming up with differentials right away, that's okay. What I want you guys to get in the habit of doing in the ICU is really focusing on the vitals and looking at the patient with your eyes, and then let that drive your differential for you. Because if you spend time up front thinking about stuff, it's going to throw you for a curveball when you see these vitals and it's like completely the thing you didn't think about. And so jump right to the vitals and jump right to seeing the patient at the bedside, like Amelia was saying. Okay, so here are the vitals. She already sort of summed a lot of this up for you. Tell me if there are any other thoughts that came up for you when you saw these vitals and what you want to do next.
I mean, it sounds shocky. I mean, he's also on pressors, but.
Okay, so these are the vitals in the ED. What are you going to be assessing now that he's in the room?
I mean, you could throw a focus on him, like you said, and while you're calling your attending or the step at echo, just to see if he's pumping blood forward. Does it look like it's the right side or the left side? Because that would kind of determine whether or not I would want to diurese him and definitely not give more volume.
Right. Yeah.
And then, again, kind of on that same vein, like, does he need something more like dobutamine? Because although I guess if he's tachycardic, maybe use heart pumping or pumping. That's kind of an initial thought.
Yeah, great. Jordan?
I mean, I think that the initial exam, certainly makes me think more along the lines of cardiogenic shock with tachycardia, cool limbs, JVD, maybe some, if there's diminished sounds, maybe some pulmonary edema or a pleural effusion. Then I'm thinking, levo is a fine pressor, and then how are we going to get fluid off of him, I think is. And then if potentially, if he's satting 88% now, would he potentially benefit from BiPAP? Do I need to have respiratory there? I think those are some other thoughts that I had.
Great, excellent. So,
and like, what's it? Okay.
No, go ahead, Jordan.
Nope. I think that's like a good start for now.
Yeah. So here, really to think about like the temporality of any admission in the ICU will essentially be like, obviously the patient is the sickest when they're getting admitted. And so you have to be at the bedside and do like reassessments in a minute span. And so what I would say is like, now that the patient is on the floor, my next step is going to be, okay, what are the vitals now compared to what they were in the ED with the intervention that's been done? So with each intervention, you're going to reassess the patient's stability. So I'm going to be like, okay, hey, lovely RN, like, once you got the patient hooked up, if you figured out, if you got a chance to get a cuff pressure, what is it now that the patient is on epi? And I'm going to assess whether I think this epi is working. And I think you guys have already brought up some great points about, hey, now I've seen an exam, I've seen the vitals, I think I know what's going on with the pathophysiology. And what the question I'm asking is, If the pressure isn't better, do I need another intervention like dobutamine, as you've already mentioned? Do I need another intervention like diuresis, right? So upfront for an admission, you're going to do interventions. And after each intervention, you're going to reassess the patient's stability and ask yourself, what other intervention do they need now? So at the beginning of an admission, you're going to do this like within minutes, right? 5-10 minutes, 5-10 minutes. And then as the patient becomes more and more stable with more interventions, you can prolong that time out to like hours. Then you're going to go back in 2 hours and be like, how are things now? Tinker with something. Then 2 more hours. How are things now, right? So you're going to come back, do those frequent reassessments. And at the beginning, it's going to be in a much shorter time span. Okay, let me just show you the labs so that you see them. Because while the patient was rolling up, you had some time to look at the chart. And here are the labs, and tell me if there's anything in here that sort of changes your mind or goes down a different path.
And Sneha, while they're looking at the labs, I think I'd throw in, like, obviously the labs are usually my next step, and thinking about like the differential you guys mentioned, looking at the labs that you have, deciding what you have that helps you address your differential and what other information you need and should order as soon as possible to try and get more empiric evidence to support whatever you decide to start treating.
Well, I think right off the bat, I mean, I don't know what his baseline labs look like, but his potassium's a little bit concerning. You know, his BUN, his creatinine, he has some obviously chronic kidney disease, but I assume these are probably much off his baseline. Wondering like if he's even making any urine, because that might sort of make me more worried about getting the RRT on board earlier. And then for his CBC, I mean, his white count is reassuring. It's only one piece, but if he has like a florid sepsis infection, I would think that that would be higher. And then, you know, lactate maybe is in that case in the setting of decreased forward perfusion causing the lactate. And then these cardiac labs or enzymes are certainly elevated, which would speak to what we're thinking about cardiogenic shock. And then to be honest, I don't write my LFTs up like this because I always have to look that up. But I'm guessing that, you know, there's like elevated transaminitis. I'm sure one of those is his DILI is elevated. And is that a normal INR though? Or
Yeah, I have a little guide up at the top.
Oh,
Megan.
yeah.
Yeah, the way I think I write them differently than other people do. And the way I write them is I write a hepatocellular pattern up top, a cholestatic pattern in the middle, the protein and albumin at the very bottom, and then INR down here. And it just helps me like see things in patterns rather than randomly scattered about the diagram.
Yeah, that's super helpful. Yeah, I think just based on what you just said, it seems like he has more of an isolated transaminitis, which could be also congestion from backup of flow from, again, the cardiac problem.
Okay, so
do we have an EKG, by the way, or tele?
I don't have it here, but the EKG shows peak T waves. Otherwise, no other like ST elevations or depressions. I've heard a lot of great things, and I think you guys are already doing part of an exercise we're about to do here in a little bit. But tell me, okay, so I'll tell you, the nurse is like, okay, we got another set of vital signs. Just put him on, 3 liters of oxygen, and his O2 sats recovered right away. So I don't think we need to do anything else there. And his blood pressure is, I've been like going up on the epi, and it's okay now. It's like 96 over 50, 60s, but it's not going up as much as I would have thought. The patient is laying there and seems tired, but is still able to interact and answer questions for you. So tell me if you're thinking about doing any interventions now, or as you mentioned, you want to look at POCUS.
I mean, I think with at least the electrolytes and peak T waves, you certainly have to deal with that and like do the calcium gluconate and probably shift him in that regard. That's an easy intervention, and then follow up with repeat labs. Then, if he's, I think I agree with Megan, keeping in the back of your mind whether or not you want to add on dobutamine or do that instead of levo, one or the other, are still good thoughts.
Yeah, and I mean, I definitely would not tout myself to be a POCUS like expert at all, but I feel like flying blind a little bit, not knowing if it's like floored right-sided heart failure, or so maybe just throw it on and get like a gross.
Yeah, I think it.
Yes, so absolutely. So this was a patient that I was admitting as a third-year senior, like in the middle of the night at Denver Health. And the reason I'm like harping on POCUS so much is because y'all have time before you have to actually do that job to learn it. And when you're in the ICU next year as seniors, ask your fellows to show you how to do a bedside ultrasound. I mean, so for this patient, what was concerning to me looking at his vitals in my exam was that his heart sounds were distant, his JVP was like very high, but his lungs seemed to be doing somewhat okay. He had this right base problem, which I was like could be an effusion, which can happen with either side problem. But he had a lot of signs of what seemed to be like purely right heart failure, and so I was like, okay, I better look and see like exactly what's going on. So I did, and
Sounds like
here's
X triad.
what I found.
Maybe some tamponade.
So I'll let you take a look at this. It's going to loop for you a few times.
I mean, if he's in renal failure, uremic, could have uremic, there's pericardial effusion, triggering heart failure.
Is the peristernal short? Like, is that his right ventricle that's compressing his left ventricle in the outflow tract?
So this is my best attempt at getting an apical 4 chamber. And so yep. So this is the right ventricle and this is the left ventricle. And then you can see a little bit of that right atrium here. The left atrium is not really well visualized in this view.
So that is a ginormous pericardial effusion then? It looks like
so this all of this here is an effusion. And what do you guys think about the size of the right ventricle?
Massive, with bowing of the septum into the LV.
The LV is like basically non-existent, right? It's so tiny.
Yeah.
I like can't even imagine it's pumping anything forward, and everything's just stagnant here in the right ventricle. You can like see the turbulent flow with all those little dots in there. Okay, so this is what I saw. The patient's still like relatively hypotensive. Let's talk about what we're gonna do. So as I mentioned, right, we're gonna think about some things we'll do in the immediate future, like right now, and then some things we're gonna do sort of planning ahead for the next few hours, end of your shift, next day type thing. So tell me what you wanna do now after seeing that exam.
Well, I think you definitely don't want to diurese him.
Yeah. So first question, let's talk about volume status. Well, fluid management. Tricky, right? Because where is this patient on the Starling curve? I don't know. Do they have too much fluid on their right side, which is why they're not pumping forward? Is it too little and I actually need to give them even more so that the right side can then push fluid into the left side? Like, it's just really difficult to assess. Okay. Do you guys want to put your money down on either way?
That's tough. I guess now I'm thinking maybe he does need a little bit of did he still make urine? Did we just figure that out?
He's like not been there long enough to see any meaningful amount of urine come out of him.
I mean, clearly with current state isn't working. I would be very hesitant to give more fluid with the size of that right ventricle. So maybe a little bit of diuresis. I don't know, Jordan, what do you think?
I don't, while in tamponade, you're certainly going to be preload dependent. I don't get the sense that this guy needs more fluid. I think he's going to need dialysis to deal with his uremic pericardial effusion.
Okay.
That's my guess.
Okay, and then I saw Amelia unmute her mic. Amelia, what were you going to say?
I guess the one thing I would say to frame, like, because I agree that dialysis is likely in this guy's future, but I think it's important to recognize how long it takes for that to get going. And then he's probably going to need some kind of management in the meantime. And so even though we know that that will over time fix this pericardial effusion, thinking about more urgently what we can do. And I guess not knowing this case, but I would say, if you knew nothing else about this patient besides the fact he was hypotensive and tachycardic with evidence of an effusion, what would you do? I guess that's how I would approach it.
I mean, you could always do a pericardiocentesis, I guess. I don't know.
Yeah. So this was, and I think I'm like downplaying how sick this patient is looking, but in real life, you like just was terrible. Like he was so unstable. His pressures were all over the place. Everything's alarming. And so I want you to recognize that this is a scenario where you aren't alone. And really the first thing that I did was call my co-senior to the bedside so that there were two of us thinking about this patient together. And then the first thing that she helped me do was call the cardiology fellow. And so what I did was we called the cards fellow. We're like, hey, we're texting you this ultrasound we just did. Tell me what you think. And he saw it and he called the attending immediately because even he was worried. And both of them showed up to the hospital 30 minutes later. So now the cards attending and the cards fellow are in-house because this patient needs an urgent pericardiocentesis because they're in tamponade. They got this huge effusion. I'm like, I don't know what to do with fluid management. I think if I do either thing, he's going to probably code. So we actually didn't mess with that just yet. And I think you appropriately picked up on, let's use some dobutamine to see if we can improve forward flow with some inotropy. So actually did start, after I talked to the cards fellow, we did start some dobutamine because remember, dobutamine works both on the left and the right heart for inotropic support. And it can decrease your SVR. So sometimes you can cause like inadvertent hypotension, but the patient's already on norepi. And so we can always titrate that if you feel like the SVR is dropping with the dobutamine. So then we had this patient both on dobutamine and norepi. And sometimes you like can't mess with the fluids until you know exactly where you are. And you can just mess with the pressors. I think you guys picked up on that pretty early on. So fluid management was question marks. We knew he needed dialysis. We're going to wait until he's a little bit more stable to like figure out what we're going to do with that. And in the meantime, you can always shift that K as much as you want. And I think Jordan mentioned that already. And so remember, you're going to call for help. I think the home fellow was like busy or whatever. And Dr. Kearns was my attending at the time. And so Dr. Kearns also came into the hospital with just like how sick this patient was. And so we had two attendings and a fellow and two seniors all seeing this one patient because he was like just so sick. And so remember that you're not alone. And if you're like, I don't know what to do with fluid management, be like, there's somebody that can help me decide what to do with it, which is the fellow, and just call them. Okay, great. So the patient is now on 2 pressors. Ultimately, we decided that he was going to get started on CRRT pretty quickly here. And so we were like arranging that with renal. And so you picked up on that already. And this patient is on pressors, so they obviously need a central line. So tell me what kind of central line you want, where you're going to put it, et cetera.
I'll defer. I'm not good at central lines.
That's okay.
Well, I mean, I don't know anything like the French and size, but I mean, I think we could probably put him a Herker since we think he's going to need dialysis. And typically I've seen those, you know, in the IJs. I don't know why we would need to access his neck for any reason where we wouldn't want the line to be there. So that's probably what I would do.
Yeah, so even for patients who might need like dialysis in the future, central lines are okay. And so the point to make here is that this patient, like if you're in the very, the thing is there are lots of pressures and lots of questions being asked of you by the nurses, and we're gonna go through some of those here in the rest of the lecture. But a lot of times you'll get here like, hey, this patient's on 2 pressors, I need a central line, I need a central line. And sometimes you like freak out and you're like, okay, fine, I'll put a central line in. We have to really sit down and think immediately and planning ahead. And so because this patient is so ill, you may forget like, oh, they're probably gonna need dialysis or CRRT soon. I mean, you end up putting something on the right side. The problem is Maherkers can really only go on the right IJ because they're so short. And you got to get it to be a central line. And so you're going to put a Maherker in this patient in the right IJ. And Maherkers can come not only with the 2 dialysis ports, but they can also have an accessory port for pressors, etc. And so I put in a Maherker with this accessory port in this patient that night. Okay, anything else that he might need that you're thinking about now versus planning ahead for tomorrow?
I would say, Sneha, anytime I'm putting a central line in and I'm planning on using it for pressure support, thinking about how reliable the blood pressure cuff is and if I might need an A-line, because I think that it can just be a little more definitive. It's constant pressure monitoring instead of every 15 minutes. And especially that if you're getting lines on both sides, you run into issues getting a cuff pressure. So I'd certainly think about that.
Thank you, Amelia. And then, yeah, so, this patient's going to get proceduralized. And so just making sure that you're like, getting an INR and coags if they haven't been obtained already, probably helpful to, in this really sick patient, send a type and screen anyway, since we're doing a procedure that's pretty sensitive. And near the heart, poking the ventricle is not, is like rare, but can happen. And then planning ahead, determine this patient's going to need a formal echo. So, thinking about that. Then we're going to have a lot to do with their renal failure and like assessing whether, making sure that we're confident that this is all just related to hypoperfusion because of his right heart failure and isn't from something else. And so, of course, you're going to have renal on board and then like all these other consultants following the patient. Nice, good job. Amelia or Danny, any other teaching points with admissions like this?
I think I would just emphasize, I know your whole emphasis here was getting support, but I have never been reprimanded, talked down to, or criticized in any way for asking for help. And I think it's something that people are happy to offer. That's why they're there. And sometimes it just lessens your workload, because I'm sure this wasn't your only admission, and maybe if alone you could handle it, that's one thing, but you have other admissions and there are other sick folks, and sometimes just the other set of hands is what you need, and that's okay.
Yeah, that was great. I would just emphasize to always talk about admissions and like run it by your co-resident, like whoever's on overnight with you, because it's a huge help if you can have another pair of eyes or someone to like help with the line while you're triaging or doing something else. So, and you can do a left IJ Maherker. They're a little bit more difficult, I think, but there are more flexible 20 centimeter left IJ lines if you really needed to do it, like if they had a clot in the right or clot in their femoral veins.
Thanks, Danny. All right, sweet. Let's go through some rapid fire questions that you're gonna get all the time doing admissions and like in the day's future. But I just wanted to pose 5 questions you're gonna hear often and how to address them. So question number 1 you get asked all the time is, hey, this patient just got intubated and came up from the ED. What sedation orders do you want? So tell me how you think about sedation in a patient.
well, I like to think about what, like, how deeply sedated do we need them to be? Are we sedating them because they are alcohol withdrawal? And so we need to make sure that we use something that, like with a GABA, and not just like the Precedex body habitus. So if they're super large, sometimes I think, don't we worry about propofol kind of sticking around longer? It also seems like it's very institution dependent as well. Those are things kind of right off the cuff. And then of the three, I think of like Precedex versus propofol versus fentanyl.
Yeah, good. So I think, Megan, you hit a lot of the points there that I want to talk about. So thinking about sedation in 3 ways is helpful. So sedation is a lot of things in once. It's anesthesia, it's anxiolysis, it's pain control, and then sometimes it's delirium control. It's all of these things sort of put into one, and you have to think about them sort of somewhat simultaneously. So the first thing we're going to talk about is controlling agitation by anesthesia. And so this is what, when we think about traditionally like propofol versus Precedex, which is dexmedetomidine, then sometimes ketamine. But I've listed for you, really propofol is going to be your go-to agent, first line for most patients. It's very rapid onset. You usually bolus it and then put it on a drip. You can use it in patients who have liver and renal injury, so you can broadly use it. And it's also protective against seizures, and so you can use it in a lot of patients that you may be worried about withdrawal. The only thing to think about is that it will cause hypotension, and then the propofol-related infusion syndrome is common, but it's time dependent, and you can think about it if the patient's been on it for a while. And then, like Megan said, you also think about like, how deeply do I want this patient sedated? Usually I think about dexmedetomidine if I'm looking for a lighter sedation, if I'm looking for the patient to still have some sort of active cognition. And then if I'm really looking for something that won't cause any respiratory depression, then that's what I'm going to reach for. But most of our intubated patients will need propofol, they need deeper sedation, and Precedex alone usually doesn't cut it. But remember, we're going to add other agents simultaneously to this. And so sometimes you can do like pain control and Precedex and get away with it. But just reach for that propofol first line, unless the patient has like a severe reaction to it. And I listed some of the other side effects for Precedex: hypertension and then hypotension, and then bradycardia is pretty common with it. And then, like Megan already mentioned, it cannot protect against seizures, and so you can't use that solo in somebody that's there for alcohol. Sometimes you also use ketamine if there are shortages of the above 2, which we did have during COVID, or if the patients aren't able to tolerate the other 2. I don't dose ketamine by myself ever. Like, I'm talking to the pump fellow or the pharmacist to help me figure out how I'm going to give that medicine to my patient. Okay, so then the next thing is controlling agitation by anxiolysis. And this is where we generally think about our benzodiazepines. It's uncommon to use just a benzodiazepine and an opiate. You want some of that anesthetic effect by the other agents we just talked about. But if the patient still seems anxious, if they're having vent dysynchrony, if they have, history of withdrawal, if they're there for alcohol withdrawal, then you can think about your benzodiazepines. Here, usually we reach for midazolam. It's a rapid onset, easily titratable, and it's useful in withdrawal. And so that's going to be sort of your go-to benzo when you're thinking about it. Start with bolus PRNs and then move to drip, because, drips, of course, are going to stick around longer in the body. And so do the bolus PRNs and then go to the drip. As you guys already know, of course, our benzos are going to cause respiratory depression, and then for a prolonged use can cause tolerance and withdrawal. And then remembering that lorazepam, if given frequently or if given as a drip, can sometimes cause propylene glycol toxicity, because that's the agent that it's in. Then sedation involves controlling pain by analgesia. And this is something we do for most of our patients that are intubated. It's like really 50-50 whether you're going to use fentanyl or hydromorphone. It's really institution and sort of nursing dependent. Just remember that fentanyl is really our go-to for patients in renal failure. And so for this patient, if you were to get intubated, I would choose fentanyl because he's in renal failure. And then we cannot use morphine for our renal failure patients. But really, fentanyl or Dilaudid are going to be our first lines. Please don't forget to put the patients on bowel regimen with this. Okay, so the next question that I think Amelia already sort of alluded to is, hey, do you want to put in an arterial line? So tell me which patients need an arterial line.
I mean, if they need frequent blood pressure monitoring, I mean, I feel like a lot of times if they're going to be on pressors for a while, certainly they're going to need it.
Yep.
And when I'm actively titrating them, I think it can be really useful.
Okay, who else? Okay, you're gonna get asked this question all the time and everyone wants an art line. It's like, no, art lines are harmful procedures. I'm not gonna put them in everyone. There are really only 3 major indications. So the first one, as we've already harped on, is patients who are hypotensive on pressors. With hypotension, the cuff pressures become less reliable and you have all these lines in them. So sometimes you can't really even do the cuff. So those patients need an art line. So this patient needs an art line. Sometimes the RTs will come to you like, listen, I'm drawing an EVG like every 2 hours and that's too much. It's becoming harder and harder. And so sometimes you need an art line for frequent EVGs and that's an okay indication. And this third one I put in smaller fonts because I get asked about it all the time, but you actually don't need it all the time. And often those cases are of hypertensive emergency. For those patients, if you've already initially gotten that blood pressure down into like the 160s, 180s, the cuff will be fairly reliable. And we're going to get those patients down to their normal pressures, hopefully within 24 to 48 hours. And I think placing art lines in those patients is really sort of overkill. And so as long as you feel like you have a reliable cuff on those patients, I try to avoid putting in art lines. And so just really for those top 2, I feel like 100% putting one in. All the other reasons somebody wants an art line are really sort of softer reasons, and think twice before you're going to jump and do that. Okay. Another question you get asked, less on admission, but like more as the admission progresses, is, hey, the patient is now on max norepi and max vasopressin. What third pressor do you want to add? So tell me what you guys think about this.
If they're on max vasopressin, the other question is, are they adrenal insufficient? Is it actually, not a pressor that you need to give, but you need to give steroids? I think that's one thing. And then if it's, going back to heart failure stuff, are you doing dobutamine instead of the other stuff?
Mm-hmm. Any other things you can think of?
Kind of went over this with Danny's same conference, I think a couple weeks ago, but some of the studies, it seems like once past epinephrine or norepinephrine and vasopressin sort of is anyone's best guess. I use like phenylephrine, or I think this person, is he on the epi or norepi? I already forgot, but you can use whichever other one they're not on.
Yes, good. So I think as we've gotten to here, normally our first line pressor will be norepi, then vasopressin. And when you're getting asked about a third line pressor, we're switching to type 2 thinking because something is wrong with this patient that isn't being fixed. And so the questions I generally ask myself when I get asked that question is, A, should I add a steroid because this patient has adrenal insufficiency, or just need a little bit of boost? Should I add inotropic support like we thought about already in this patient? And is that what I'm missing? Should I add bicarb? Why would that matter?
I mean, if they were supremely like pH 6.9, where then they can't even respond to the catecholamines due to the protein unfolding or whatever.
Correct. So some of our pressors don't work at really low pHs. And so I'm thinking, hey, do I need to get an EVG, check a pH? And do I need to put this patient on a bicarb drip to help my pressors actually work? And then the last thing is, what am I missing? Is there ongoing sepsis? Are they profoundly hypothyroid? Do they have a brain injury? And this is a neurogenic hypotension. And then is this iatrogenic? Like, are they on 100 of propofol all the time? And they're like, hypotensive because of that. And do I need to change my sedation? Add something else that won't cause so much hypotension? And so when I think about third line pressors, I'm really switching to this type. And then, yeah, you can always use these agents that Danny taught us about.
Sneha, can I make one point real quick?
Please.
For the bicarb, so the bicarb drip itself is going to be pretty ineffective when you first start it because there's just not that much bicarb in a bicarb drip over the duration you're going to run it. And so it's pretty low risk, high reward to just push an amp of bicarb at the bedside and see if their blood pressure responds and their pressure requirements get better. And then if they respond to that, you could keep intermittently just pushing bicarb amps to get you the same effect with less volume, or you could start the bicarb drip after that. So I would sort of think of it more as a bicarb load with an amp at the bedside while you're like waiting for the fellow, and then start the bicarb drip after that, because you're not going to hurt anyone by giving a bicarb drip, bicarb amp in this situation.
Sweet, thank you. All right, the next question you're going to get asked is in a scenario where a patient coded on the floor, now they're getting transferred to your team on the ICU, and the nurse asks, hey, do you want to cool this patient? So how are you going to answer that question?
I mean, I think there's a trend towards cooling both in and out of hospital arrests now. I forget what the most recent study is, but I think most people do cool nowadays.
Jordan, do you cool everyone that arrests?
Probably not. By the way you're asking it, but I think in a lot of scenarios you do, but yeah, probably not everything.
Yeah, so I basically make these conferences based on the things that I didn't know when I was doing all these admissions. And like one night the nurse asked, hey, do you want to cool this patient? And I was like, okay, I don't actually even know like who I'm supposed to cool. And I've presented this slide before, but I'll just re-present it for you guys moving into senior year is targeted temperature management. Remember that people we cool are those that are not following commands and that have a neurologic deficit after ROSC. And so that's why we don't cool everybody, because if the patient achieves ROSC and is like interacting and moving all their extremities and following commands, they don't actually need to be cooled. It's the people that aren't following commands and have a low GCS that need to get cooled. So you're going to need to do a neuro exam. And then the, thinking immediately, thinking ahead part is in this patient, remember that they're going to need a cooling catheter. And so thinking about when you're putting a line in that now I'm going to need to put a cooling catheter in instead of just a regular central line. And then the how you cool is sort of protocolized with our nurses depending on the institution you're at. And then just remembering that you're going to have to watch out for some side effects of cooling, but we won't get into that today because that's a few days later after the admission. All right, and then last question is the patient is on CRRT and the nurse asks, hey, what is the net goal you want for this patient? What are you going to tell them?
I think it would depend on how things went with the pericardial synthesis. And like where we thought they were on their Starling curve. Obviously, the patient was volume up, but we talked about just the challenges of not wanting to, affect their preload if they were preload dependent still. And I think with cards, I feel like I remember them saying you don't want to fully drain the entire effusion, depending on how long you think it's been there, because they can kind of go into a reverse, but they can have complications from that as well. So I think I want to defer and say need a little more information based on how that went.
Yeah. Jordan, any comments before I tell you my spiel on this?
No, I mean, I agree with Megan. I'd be in consultation with our colleagues, but I think in the interim, when we didn't know if we were hesitant to give fluids or remove fluids, you can always just say run net even.
Yeah. Yeah, good. So basically, the nurse is asking you a much more complicated question than like what this seems like. So our nurses are really good in the ICU and they're doing a lot of calculations for you behind the scenes. So when they ask you this, they're not just asking about the CRRT or just looking at the CRRT. what they'll actually do is they'll calculate all the I's and O's. And so they'll look at, hey, how many drips is this patient on? Sort of like Danny mentioned, like if you put another bicarb drip in, that adds volume to this patient. And so for our patient who's like in tamponade and we're thinking, hey, I'm probably gonna have to diurese them at some point. If we're giving all this fluid, that's not great for them. So they're gonna calculate all the ins, they're gonna calculate all the outs, and then they're gonna set the CRT machine to give you your goal. So I'm like, okay, this patient is septic, they're hypovolemic, I need them to go net positive. So I'm going to run the CRT so that ultimately all the I's and O's calculate out to net positive. And these rates are like 100 an hour, 250 an hour, whatever you want it to be. If the patient is really volume up and I need to diurese them, then I'm going to ask them for a net negative goal. Okay, can we do net negative 100 an hour? And then sometimes we just want the electrolytes and stuff to be filtered and the volume status is actually okay. And so you can say, hey, I want net even, no fluid in or out, just run for the electrolytes. Does that make sense? So basically your answer is going to be what you want to do with the patient's volume status and hemodynamics, and then the nurses will adjust all of the rest of this. Okay, and then this I'm sure you're all very familiar with already, but I just want to talk about one last time is for every admission, now that you're in charge, you have to think about your checklist. And I have to sit down and think about it very in detail for all of my admissions. So I'm thinking about, hey, this patient needs to get fed. They're probably chronically ill or currently are severely ill, and they need good nutrition to be able to heal. So I'm thinking, hey, do they need an OG tube for enteral feeds? Do they have a PEG tube for that? If not, am I thinking about some type of long-term parenteral nutrition if they have a massive GI problem going on? Versus can this patient be extubated tomorrow and have oral feeds, and so I'm not going to worry about this tonight. And then ultimately, I have had cases where I like forgot about nutrition, and when I say I mean like the whole team just kind of forgot about it. And then the patient's having a bigger and bigger anion gap, and it's because they're starving. And so sometimes if you're really not going to do either of the first two, just think about, hey, does this patient need just a little bit of dextrose so that they have that glucose and not go into anaerobic metabolism. So just please think about their nutrition. You're going to think about lines. This is mostly to help D-line in the future, thinking about, hey, do they need a Foley catheter now, day 47 of this admission? For sedation, you're going to come up with your sedation goal. For most patients, it's like -1 to -2. Thinking about DVT prophylaxis, thinking about peptic ulcer prophylaxis, which is indicated in all intubated patients. Thinking about bowel regimen, especially for those on opioids, which is most of our intubated patients. The nurses and PTs are great about early mobility in the ICU, so we don't truly have to worry about this too much, but thinking about if you have a massive stroke patient, how early should I involve PM&R to see if they're going to qualify for acute rehab is something you should be thinking about. And then, of course, code status and DISPO. When do I anticipate this patient be able to go to the floor is something I think about routinely. So thank you for all the interns that participated in our series. Any other advice, Amelia or Danny, for our interns who are going to be admitting to the ICU soon?
No, I think that was great. I think, yeah, like you said, the big thing is, to me, the most important thing is recognizing your limits and asking for help.
Yeah, completely agree with Amelia. Just ask for help if you have any questions or concerns. No one expects you to be a brilliant ICU doctor. You're like first day of admitting to the ICU, and that's why there's fellows and attendings and your colleagues. So do not hesitate to ask for help.
I am not so great about keeping track of patients.